I was walking through the thermoforming department the other day, and our splint department, and I saw an RX from a doctor that said, please fabricate a night guard. Please help me with design due to undercuts and rotation of teeth. I'm not sure which material to use or even which arch to do. And that's something we actually see pretty frequently, especially in a case like this. You know, you look at this upper and you can see that we do have some rotations. We've got a lateral that's tilted to the lingual, and then a central that's out to the facial as well. And anytime we get a couple things like this, especially if we're looking at draw and we rotate this model so we can see, we want to be able to see straight down on that central, and then we see the undercut that we're going to have here on that lateral incisor, and then we'll also look at the sides to see how much retention we're going to get. The teeth appear to be tilted just slightly into the to the palatal aspect, and so it doesn't look like we have a ton of undercut here. So by the time we block out everything, so it's going to go on and off, we're probably going to have something that fits kind of loose, especially like this just happens to be a straight hard splint. This is the kind that we made for each other in dental school, at least at my dental school, and this makes up about probably 15% of the splints that we make, maybe 10 to 15%. And on these hard ones where there's no give at all on the inside, we definitely have to block it out and make it fit looser if we want to have hopes of it going on and off an arch like this. So perhaps a better choice, if you really wanted to do that, would be our hard, soft, extra comfort splint. And the comfort splint, you can take it with your fingernail, and it's got that soft inner layer. So the outside's still the hard acrylic, but the inside is the soft inner layer. And so now there's some give. We don't have to block it out quite as much because we have this flexible layer on the inside. So that would probably be a better choice in a case like this. But most patients will complain when they've got a couple teeth that are out to the facial, like this central. They will complain that they can't get their lips together when they're trying to sleep. So obviously our mouths usually close and our lips sealed, and then we breathe through our nose while we're sleeping. And this, when you've got some teeth that are facially positioned, it really makes it big and bulky and difficult to be able to get those lips together. So that's not a very comfortable split. So we suggested that the doctor go with the lower, and I dropped this and just broke it. I apologize. A minute ago trying to carry too many things. But as we look at his lower arch, we've got a better chance of the rotations not being a big issue here. Even with the incisal edges on those two teeth, it looked okay. And so sometimes that decision between making a maxillary or a mandibular splint, sometimes it almost probably doesn't matter. One way we kind of help a dentist decide is that if there's teeth missing on one of the arch, a couple bicuspids or maybe a molar as well, we'll usually make the splint on that arch to kind of stabilize things a little bit better if we have some missing teeth. If we've got a severe class 2, we're going to probably do it, well, not probably, we're going to suggest that you do it on the maxillary arch, because with the mandibular arch, if we have a significant class 2, we've got somebody who's way back here. If we're going to try to do that and get proper anterior contacts and guidance with the mandibular splint, it's really not going to work. In the case of a really deep curve of SPE, which we don't really have here, that's pretty normal. We're going to go with the mandibular splint for a really deep curve of SPE. And one of the other nice things, a mandibular occlusal splint, it kind of encourages the patient to put their tongue in a better position, kind of the anterior part of the palate, because it wants to sit on top of this splint. And so if it's somebody who could use a little help getting their tongue forward, that mandibular splint is going to be better for that as well. But either way, it almost doesn't matter which one. I know some dentists have very strong opinions about which arch should be used. In this case, though, things definitely look better for the lower, and I'm going to bring a cup of hot water over to show you this splint that we've done. This is one of our flexible splints, and this Astron splint, it's steaming just a little bit, kind of not too hot. I just microwaved that for a minute, but You've probably seen me play with one of these before. These are the flexible splints, so you can see that now I'm able to move it back and forth and this way and that way. And so this is the whole material. There's no soft inner layer. But when we do have an area where we don't want to block out too much, because even looking at this lower, you go, yeah, well, no mechanical retention here, 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 here. Some around the anterior, not really much mechanical undercut here when you look at these teeth. And so that's why something like this, where you can heat it up and pop it onto the teeth, will do a better job. If you were going to do a splint on the upper, you could certainly consider one of these as well, because it really kind of molds itself around those teeth. And so if the patient also doesn't wear it for a couple of weeks at home and they go to put it back in and it's very tight, all they have to do is heat the coffee cup full of water in the microwave for about 2 minutes and heat this up, and this will become flexible again. Put it in their mouth and close down on it and be able to kind of have it re-engage some of those undercuts, or if it felt like a tooth, like on an upper, whenever you see somebody who's got a tooth like this, especially it seems when it's out to the facial, when they put a splint in and it hasn't been in for 4 or 5 weeks, it'll really feel like it's moving that tooth back towards the palatal. It'll feel like you're doing some instant orthodontics, and they'll even get a headache. And being able to heat up one of the flexible ones in a condition like this too will take some of the pressure off that tooth. And so these aren't quite as durable as the other splints, the full hard and the hard soft comfort splint. But anytime you've got some rotations like this, or if we don't have a ton of undercut and we're not going to do any block out, using one of these ones that can be molded either in the operatory or at home by putting it in the hot water out of the patient's teeth can offer a very good solution. And just one bonus case, this is one of the fixed technical support people brought this over to me to take a look at it and said, have you ever seen anything like this before? Well, when I look at this side of the impression, the first thing that I see is it looks like obviously we have half the tooth kind of biting on the tray, so it's probably safe to assume the patient didn't get all the way together on the tray, but it's the impression itself, and actually not a bad job of getting the margins there, but not much in the way of tooth structure besides those 3 little indentations that were prepped. And so when you pour the model, this is what it actually looks like. And if you look at it from the buccal, you'll see that there's not a lot of. That's what I would call a short clinical crown. A very short clinical crown. And so there's those 3 holes that were prepared in the tooth. And again, cord was packed, or a diode laser was used. It actually looks like cord because a diode probably would have left a few kind of tissue tags here and there. A little guessing maybe on the mesial. But I'm guessing this is a vital tooth. I think that's probably pretty clear, or there probably would have been a post and core. And so we've got those 3 little retentive potholes that have been prepared. So you look at this, and even with those 3 potholes, even if this was going to be a cast metal crown, I mean, just the size of the crown, though, to reach the opposing tooth with only those 3 little pegs, you could see those, snapping off quite easily, even if it's adhesively bonded into place with something like Panavia or CNB Metabond or maybe even Total Etch. That's a lot to ask of that. So, maybe the patient didn't have money for crown lengthening, or the dentist didn't want to do it. But you can see we would really be able to benefit from a little additional tooth structure here. And I don't know, I think a lot of dentists would look at that and kind of consider it non-restorable if they, couldn't put some pins in here and build it up too. That's obviously kind of another suggestion would be to put some pins in there and build it up. That's still an awful big buildup for a couple pins, but if you're going to do something heroic like that, that probably stands the best chance. And then maybe if we can grab another millimeter and a half down here for a little ferrule effect, we would end up being okay. Even then, we'd end up telling the patient, I'm not sure how long this is going to last, and I'm sure there's a fair amount of dentists who would either say, look, we almost have to do an intentional endodontic procedure just to be able to put a post and build up in there. And there's probably a few dentists who would just say, oh, that tooth, at this point, not really serving us very well. Maybe it'd be a good idea to put an implant in there. But this just ended up on my desk, and I thought it was curious because I'm not sure there's any way we're going to make something successful there. But I've never really seen something like this done as well too. The dentist did prescribe a PFM crown, so it's not like it's going to be anything, some sort of kind of tricky crown. It's just going to be a PFM crown with 3 little legs in there. But if anybody knows what the dentist was trying to accomplish here and whether you've done it and if it actually works, please drop us a line at Chairside Live and let me know. Otherwise, I just thought it was kind of curious and something that I wanted to share.